Good afternoon, and welcome to our webinar, Is Female Genital Mutilation and Circumcision Happening in Australia? What Health Professionals Need to Know. Our webinar is brought to you by the Multicultural Centre for Women's Health and specifically the National Education Toolkit for Female Genital Mutilation or Circumcision Awareness. That's NETFA in short, and that's a NETFA project. I would like to begin by firstly acknowledging the land we're on. This is to acknowledge the Gadigal of the Eora Nation, the traditional custodians of this land, and to pay my respect to the elders, both past and present. I am Buipelo Besele, the Senior Project Officer for the NETFA project. And I'm not alone in studio. I'm here with a panel of experts, an all-female panel, acknowledging, though, that even though we have females and the experiences we'll talk to will be about females or women in health settings, we do acknowledge that men too have a role to play when it comes to ending female genital mutilation or circumcision, and there are more resources to this effect on our website. To introduce my panelists on my left, I'll begin with Juliana. Juliana Nkrumah is the domestic violence project manager, that's correct. She has many roles. The domestic violence project manager at Settlement Service International. And she's also actually a NETFA advisory board member. Next to her is Professor Angela Dawson. Welcome, Angela. Angela Dawson is a public health social scientist with expertise in maternal and reproductive health service delivery to priority populations in Australia and low and lower middle income countries. Welcome. And next to her, we have Associate Professor Shanti Rama. Welcome. Consultant pediatrician and Associate Professor Shanti Rama is currently the Director of Community Pediatrics at Southwestern Sydney, where she is responsible for clinical services in child development and child protection in the region. And next to her, we have Fatusila. Welcome, Fatusila, a young advocate, very passionate about speaking to issues around female genital mutilation and circumcision. And she is a survivor, and she'll be sharing some of her experiences in the health setting. And next to her, we have Dipti Zakaria. Welcome, Dipti. Dipti is an emerging thought leader and community development professional with experience in the multicultural health and population health in the public health sector and learning and development in the private sector. Currently, you are based at Western Sydney Local Health District. Welcome to my panelists. So in terms of the format for today's presentation, it'll be a panel-style discussion where I'll ask questions to the panelists, they'll respond, and then at the end, we should have time for a question or two from the audience. To contextualize our webinar for today, I'll draw insight from the Australian Institute of Health and Welfare report for 2019 towards an estimate of the prevalence of female genital mutilation and circumcision in Australia. The report estimates it gives us a prevalence of around 53,000 women currently living in Australia who have undergone female genital mutilation or circumcision. Juliana, I'll pose a question to you. Are there 53,000 women, an estimate, who are in Australia and have undergone female genital mutilation or circumcision?
I don't know where that figure has come from, and I seriously want to applaud the Australian Institute for Health and Welfare for coming up with a figure. But I suppose it's by derivation, deriving the information from the global percentages from countries that have moved to live in Australia. So that's all that I can say. I'm not sure that we have as high a number as 53,000 women. However, that's the number that we've been given.
And is that a reality, though? Can we safely go with it and say there are women in Australia who would have experienced female genital mutilation or circumcision?
Absolutely. There are women in Australia who would have experienced female genital mutilation or female circumcision prior to arrival in Australia. We don't know any woman, we haven't got any information about women or young people who are being circumcised in Australia. All we know is definitely women who had their circumcision prior to arriving in Australia are in the Australian community.
Okay, Juliana, and I'm sure we'll talk about that even more and really pull it apart and get a better understanding of that. But Juliana, from my understanding then, given the minimal, I suppose we could say, safely say sort of minimal instances, as you say, then of female genital circumcision or mutilation happening in Australia, is it then not an issue out there, a global issue, or perhaps an African issue, that it doesn't affect women in Australia? Why the need to discuss this?
Female circumcision is a global issue. And we have statistics from World Health Organization about the global prevalence of female circumcision. World Health Organization puts the statistics at 200 million women and about 14 million per year that are at risk of female circumcision. That is the global statistics that we are working with. And when you go down the number of countries, there is information about the percentages of women in countries where female circumcision is prevalent. That is being given. Now, when you look at those numbers, it becomes almost an epidemic because 200 million women is quite a large number of people. But, you know, it's because it's a cultural, traditional, gendered practice that has no health benefit. We should understand that due to migration, people will be moving into Australia who have the practice as their culture and who also have their practice having been done to them and who have in their mind an understanding that it has to be perpetuated. And these are the areas, this is the context in which we are operating, in the fact that it is a cultural, traditional practice. It's gendered. It's also something, a practice that women value to a great extent. So there is a lot of instances where women feel like it's important for them to continue, and yet they are in a new country where the rules might not be supporting the continuation of the practice.
Thank you, Juliana. Thank you for those responses. So we have established that women in Australia, living in Australia, migrant women, that there are women who would have undergone or experienced female genital mutilation and circumcision, and therefore that there is a continuing health risk. I'll draw on my health experts in the room, starting with Professor Angela. Professor Angela, what are the implications then for migrant women in the health sector who have undergone female genital mutilation and circumcision? What does this mean?
Well, first of all, just drawing on that figure of 53,000, that rough guesstimate, of that amount of women will know that nearly 60% of those women will be of childbearing age. So there are implications for pregnancy and childbirth. And as we have received more and more women from countries where FGM is practiced, clinicians are seeing more women in their clinical practice with FGM. So a study we did at Auburn Hospital showed that between 2006 and 2012, we had an increase of from 1.8 to 2.6%, and work done by family planning shows that there's been an 11% increase in women presenting with FGM from 2009. And so clinicians are seeing women with FGM at Auburn Hospital, at Canterbury Hospital, in Melbourne, at the Royal Women's Hospital, and in Perth. So women are presenting. And I suppose in terms of pregnancy and birth, the biggest issue really is around obstructed childbirth, and this is particular to type 3 FGM, which requires, we recommend antenatal deinfibulation. However, I've got to emphasise that compassionate, woman-centred, culturally competent care is central at all times for women who are presenting. And we need to remember that FGM is illegal, so that reinfibulation is also illegal. And we know that from studies, a survey of RANSCOG respondents a few years back, some clinicians had been asked by women and their partners for their woman to be reinfibulated. So we know that with the right care, pregnant women with FGM who are cared for by staff who are trained can have similar outcomes. And research we've done in Sydney has shown that, a cohort study we did. And we know we've got lots of guidance, we've got guidelines, RANSCOG, we've got a lovely continuing professional development module, and we've got various resources actually that have been produced by New South Wales Health. However, health outcomes for these women overall are not similar. There are increase in episiotomies and perinatal trauma for many women who come from FGM prevalent countries. There's problems with the maternity care. Women aren't always satisfied with the care that they receive. Health professionals actually have reported being lacking confidence, lacking knowledge, there are gaps in clinical compliance as well, despite having some really good guidelines. It's a very good study in Perth showing differences in care. So what we really need to think about is the fact that when quality care is delivered, when midwives, nurses, doctors understand a woman's socio-cultural context and her values and her goals for health. And this is really important to shared decision-making. And so what we need to make sure is healthcare decisions are based on what women want. And so what we're actually working towards is developing a tool to guide healthcare interactions with midwives, GPs, and actually child and family health nurses as well, to improve that point of care experience for women with FGM.
Thank you, Angela. And just to backtrack, because you did lose me a bit there, you spoke about type 3 being the riskiest type of female genital mutilation or circumcision found in a woman in a maternity setting. And you spoke about defibrillation and refibrillation. But can you break it down for us and as an audience, to our audience members, to really understand what is type 3 then? What is the presentation there and why it would be a health risk?
So type 3 involves the removal of the clitoris, the prepuce, the minora and the majora in various I just have to emphasise that this practice differs widely. There is not one practice that one group will undertake and another group another. There's vast variation across different ethnic groups, different cultures in different countries. But WHO has clear guidelines on the different types. And type 3 involves removal of external genitalia and the stitching together the vulva to leave a small hole for menstruation and urination. And when a woman is not deinfibulated or cut, to open the area for childbirth, then we can have an obstructed labour.
Okay, thank you for that. Thank you, Professor Angela, for clarifying. And then we move on to Associate Professor Shanti, or Dr. Shanti Rama, because she also works in the clinical setting, from my understanding. She's a paediatrician and working with communities and children. Can you explain the challenges when it comes to dealing with issues of female genital mutilation or circumcision in a health setting?
Yes, certainly. Thank you very much. Well, my experience comes from dealing with culturally diverse populations, both in our refugee clinics in southwestern Sydney, which has the largest refugee population in Australia, and also in my clinical role as child protection lead for southwestern Sydney. So those are the two situations in which you encounter either the concern about FGM or circumcision or the knowledge that this might have taken place. The challenges for us as health professionals in this country are that there's not a lot of experience with FGM. There's not a lot of it seen either. So in the best available study that we have that I participated in a few years ago, we know that only about 2% of paediatricians acknowledge they'd actually seen or experienced children who had had FGM performed and mostly done somewhere else. And when we looked at the total number of children that had any documented procedure, it was not even 60. This is all of Australia. So the challenges are there's not a lot of experience and not a lot of children or young women being encountered by clinicians. So I guess the challenge is for us to make sure that those of us who practice clinically in women's health, child health, general practice, and deal with culturally diverse populations, particularly populations that are coming in from the vast array of countries where some form of FGM actually is practiced. Those of us who work in these situations do need to upskill, do need to know about what FGMC entails, how it might present, either in gynecology, obstetrics, or more critically in child health, because if it's happening early in life, pediatricians are the ones who might encounter it. The other thing we do need to know is there is a big range of procedures. There's also very many differences in the patterns of the types of FGMC we see, whether it's from Asia or Africa or the Middle East. So I guess some knowledge and understanding is very important, because in the survey that we did find out, like the obstetricians, that pediatricians felt they needed more information and more knowledge about this issue. So I guess our take is that clinicians do need to know that you may encounter it. They need to know about how to think about it in a culturally relevant, sensitive, culturally congruent context. So at the very least, I think all of us who work in populations where there is cultural diversity, you need to know your population. You need to know who is coming your way. You need to know what they might present with, and you need to deal with it in a very sensitive way. And also all of us need to know the legislation completely does not support it in this country.
Yeah. Thank you, Dr. Shanti. I hear a lot of in needing to know, and that pediatricians or medical professionals need to upskill. But are we then, if I'm correct, are we encouraging screening of children then in needing to know?
No, really, this is not what I would advocate, and no one would really advocate that. So the people that I regularly talk to, the cohort of pediatricians and child health specialists who work in refugee-specific practices, we have a network, and we do talk about what's the best way of addressing this issue. Certainly my colleagues in Perth, Western Australia, have a very interesting way in which they actually make sure that the girls that they see haven't had this procedure. What we are saying is that be aware and be sensitive to the ways in which it might present. So it might present in very innocuous ways. So recently we had a mum who just delivered her third baby. She's from Southeast Asia. And in passing, she told the midwife that because this was her third daughter and the previous daughters were born in Malaysia, she was wondering about whether she would get the procedure done. It was a very innocuous little offhand statement. So that it can happen in that way. In another situation, it might be that clinicians encounter girls who have problems with pain or urinary tract infections, or they're concerned about how they look and how they might progress to be sexually active or have, pregnancies and that sort of thing. So it can present in all sorts of ways. So I just say that our clinicians need to know that they have to have their antennae up. We don't believe that you should be screening everyone. Most children who come, whether to refugee clinics or to our other kinds of clinics, don't present with that as an issue. They come because they want their well-being looked at. Yeah. So I think that we would definitely not talk about screening, but I think upskill child health and women's health professionals to know the range of ways it might present and be sensitive in looking for it and asking about it.
Thank you, Dr. Shanti, for clarifying that for me. Next, we've heard from the clinical space, those working in the clinical setting or health professionals. And so we've identified the challenges there when it comes to issue of dealing with female genital mutilation and circumcision and identifying the health risks. And now I want to hear from the community side. What are the women saying? What are the challenges they're finding in approaching clinical settings or health health settings seeking help or assistance and support having experienced or undergone female genital mutilation and circumcision. We've got Dipti in studio and we've got Fatu. We can hear first from Dipti, who works with women in the community.
Thanks, Boy. So I work with Western Sydney Local Health District, and I'm responsible for the New South Wales education program on FGMC. And just to take off from what Dr. Shanti said, you know, the need to know your population. And I think that's really important for us as health professionals and clinicians, because there's immeasurable value to human existence and interaction that spans all narratives, belief systems, and culture. So knowing our people, and Angela just shared about person-centered care, and it's important for us to understand the women we engage and meet and support them in their journey. There are a lot of challenges women face, you know, from a health literacy perspective. A lot of our women who are presenting and who are coming for care are not even aware that the FGMC that has been done to them is impacting their health. So it's usually dismissed as women's troubles. So when I don't understand it and I don't think it's wrong, how do you expect me to disclose? And as health professionals, we need to be able to draw that out to make women feel comfortable, safe, and for them to be able to trust. We've had women who've actually shared saying they felt cornered, guilty when health professionals have reacted differently. Like they've never seen a woman present, and they're afraid themselves and they don't know how to respond, and that kind of isolates the women. Or when their husbands have been questioned. And a lot of our clinical panelists have shared that a lot women have been done when they were younger as little girls, so some of them don't even remember. So it's important not to blame, but to be very, very respectful in our interactions with these women. And some of these women, we're fearful about the consequences of any procedures being done. We've had our women share that after they've had a baby, they've not been provided enough care in the postnatal space. They've not been asked questions, how are they doing? The focus has been on the baby. So asking open-ended questions, building their understanding, empowering women to make decisions for themselves. And it's very important to understand that we respect where they come from. We respect every woman for who she is and meet her at a point where she wants to be met. And going back to what Angela shared about shared decision-making, about helping me to make my own decision by keeping me informed and starting from a place of deep understanding and value. And I think women appreciate it because a lot of them are not even aware of sexual reproductive health, how their bodies look. So we've encouraged clinicians to use visuals, to do anything to support and get women to respond effectively. So our program has two parts to it. We work with our communities, both men and women, to increase their understanding and to be advocates, and also with clinicians to help them develop their ability to work with our communities. So trust, credibility, and rapport are key in cross-cultural interactions. Boy.
Thank you, Dipti. Thank you. Next to Dipti, we've got Fatu, who would have experienced female genital mutilation as a young girl growing up in Sierra Leone. She then moved to Australia at a later stage. Fatu, can you tell us about your experiences in health settings, your initial encounters with GPs in Australia, and having experienced female genital mutilation or circumcision and seeking assistance?
When I started seeking support from GPs, I was maybe 15 years old, just because I was just finding out what my body, like what has happened to me. I wasn't even concerned about FGM, but I knew that FGM has happened. Going to the GPs and then telling them that I have gone through FGM was kind of like, I just felt like I wasn't giving enough support. A lot of the doctors, they were unaware of what FGM is and what exactly has happened to me. So I was sitting there, I would probably be educating them instead of being the patient, I was more of the educator. I think that annoyed me a lot because it kind of re-traumatizing me of what has happened to me, something that I don't want to talk about it because I am not ready yet. So that pretty much made it hard for me to seek help, and I became more numb and not talk about what has happened to me. And instead of seeking help, I would just get Panadol or something like that. But, you know, I would not go to the doctors because I didn't want to be teaching them anything. Yeah.
Thank you, Fatu, for sharing your personal experience of having undergone female genital mutilation and circumcision as a young age, and then once having arrived here as a refugee, correct?
Yes.
As a refugee, and then later on as a teenager seeking help. And I guess the difficulties and challenges with navigating the clinical setting and approaching your GPs to try and get some sort of assistance. So we've identified then so far in this webinar that, you know, they clearly identify challenges within the clinical setting where pediatricians or your medical professionals seek or need that understand. There's a need to understand more around female genital mutilation and circumcision because there are women presenting with these issues. But how then do we deal with this? And then from the community side, the women themselves are saying, you know, there is that need. They do find they have issues or health challenges where they'd like to seek help in clinical settings. But these are the challenges when encountering GPs or health professionals. And so clearly there's a need to bridge that gap. And so my question then is, what are the solutions? How do we bridge that gap? Understanding that, you know, ensuring optimum health for all, including women, migrant women, is a right, it's a basic right. So my question then goes to Shanti. How do we begin to address these serious and urgent challenges?
Yeah. Well, I think we've all talked about how we need to support quality care.
Yes, yes.
There is a big movement internationally about respectful maternity care. There's certainly a big movement around children's rights in health settings. So we very much feel that it is a right. Health is a basic right. And the way we deliver healthcare is about promoting children's rights, promoting human rights, and promoting us to achieve the optimum health and well-being. So I think we need to work within that framework, that it's a rights-based framework. So we go back to saying those of us who work in the clinical space, and also, I guess, public health and research and academia, need to know our population. Knowing who we are seeing, who is likely to come, and preparing for that is really important. That doesn't mean you target or you racially profile people as happens in other settings, which is not a very good way to go about it. I think it's about making sure that all of us who work in this space are aware of the range of procedures. I mean, I think we need to be broader in our understanding of what cultural and traditional practices involve, both for girls and for boys, and that there are many cultural practices that we support and we absolutely celebrate. So we need to understand that there is a space for cultural practices, cultural beliefs, cultural congruence in everything that we do. But we also need to take a very strong line and say, when it is about the rights of humans, we draw the line at any practice that violates those rights. So we need to think about the way we deliver care to be respectful, but also promote young girls and women's well-being in the best way we can. That will mean working from where they are. If someone's not ready to talk about it, they're not ready to talk about it. If someone's very ready to get help and information, as Fatu talked about, then we really need to be ready and waiting to provide that help. I'm talking a bit in generalizations because I recognize that it is quite a widespread range of procedures and practices. And it involves everything from type 4, which is a little nick that you can't even see when children present to you later in life, down to very, very significant changes done to women's genitalia. So I guess we need to be aware that there is this widespread practice. And because we live in a globalized world, we know that, migration and movement is the name of the day today. We need to be prepared for young women, girls, and older women to present to our settings in a range of ways, and we need to be ready to deal with them with the best possible clinical care, quality clinical care, and also respect.
Thank you. Shanti.
I think also
Yes.
treating individuals as one person, not generalizing the whole thing, because I have experience where I'll go to a doctor and they'll be like, well, I've seen this person that have gone through the same thing. That doesn't make me feel anything better. Like, it made me feel like you're just generalizing the whole situation. My situation could be different to that person's situation. So treat me as an individual and treat me with respect, and don't just degrade of my information and just categorize it with the other information that was given to you previously.
Yep.
So I think that's a major thing where we just generalize rather than be treated as individual.
Thank you, Fatu. Thank you, Shanti. Now, Shanti, I'm not a medical expert, but I want to throw another question at you, probe you even further, because you've come out strongly about this, and, we need to get our act together, I guess, in short. But I, as a doctor, could possibly say, maybe I want to just specialize in a certain group or population. Am I obliged? Is it optional? Where do things like duty of care come in? Or is there a code of conduct? I don't know, because I'm not a medical profession.
Yeah.
But is it optional to care for, other women? Do I have to?
Yeah, we do have a very strong code of conduct. I think, all people who have come out of doing whatever medical degree they've done, they have actually had to go through the Hippocratic Oath. But this is much broader than just doctors. It is really about care that is across the spectrum. We have nurses. In fact, more nurses would be saying this, and midwives than doctors. And we have a whole range of allied health professionals as well. I think GPs are very important. All of us have a duty of care to provide the best possible and respectful clinical care. So I think we do. We have a very strong duty of care to make sure what we do is good quality to everyone who comes our way.
Thank you. So no options there.
No options, no.
Clearly understood. Professor Angela, 2 or 3 key recommendations to provide to health practitioners in the clinical settings and when encountering issues of FGMC.
So I couldn't agree more with respectful rights-based care and continuity of care, the importance of ensuring that health professionals are all talking to each other and all working together, and that women are not educating health professionals. In fact, I would strongly recommend that education on FGMC is included in all healthcare curricula, so for doctors, nurses and midwives, and that these professionals work across in terms of pregnancy and childbirth and into postnatal care, ensuring that GPs, midwives and child and family health nurses and obstetricians and paediatricians are all on the same page. And I would also recommend that we support our clinicians to deliver good care, not only through education, but tools and guidelines, and that these should ideally be co-produced with women and partners and communities being involved, not in educating in their own personal consultation, but by co-producing materials and education for health professionals, for social workers, and other professionals engaged in health and community care. So, yes, I think we all need to be on the same page and working towards respectful right-based care.
Thank you. Thanks for that, Dr. Angela, Professor Angela. Dipti, insight from you. So what are key recommendations? What are the women suggesting? What would work better for them in clinical settings?
Just endorsing what Professor Angela just said, it's important that the clinicians are educated on what this challenge and issue is. So we do have the New South Wales education program on FGMC. We do have clinical guidelines that are available. And we also have training available for our midwives, our doctors, on what is this issue from a cultural, social aspect. So training is provided. We have access to the NETFA website. We have other important guidelines that New South Wales Health has put up that they can access. And going back to a co-design and partnership, our program runs a strong bilingual community education wing. So we have community members who represent and advocate, who can come as representatives and talk to clinicians. So there's our overall overarching framework and support mechanism for our clinicians, tell them their stories, because it's not what we hear. We're bringing it's not the storytellers here, but the people who've actually experienced it, like Fatu, who can bring a completely different angle to what they've gone through and how they would like to be supported. So we have access to that through our program, which is important for clinicians to use.
Thank you, Dipti. And Fatu, from your experiences then, because I understand that things are working right now, it's taken you this long, maybe 28 years of your life to finally get help in a medical setting and deal with issues you may have experienced from female genital mutilation. What's working? What worked for you? What's your journey like now?
I think what worked for me was I was given a platform to share my story, and because I was mutilated at such a young age and I had no idea what happened to me, and then going through puberty and then finding out my own body, it made everything complicated as well, like with urinary tract infection, post-traumatic stress disorder, and depression, all those stuff. So I wasn't sure exactly where all this come from. So as I grow older and then get to know my own body and then be more educated around FGM and everything and my body image, I decided to seek help in the professional setting, and that took me a while as well, finding the right person who is gonna actually train me as a person, and I can be vulnerable as well without being forced to be vulnerable, or can trust them easily. So it only took me 28 years. So this year, February, I started seeing a psychologist who is from Egypt and a female that's same age as me. And as soon as I sat there, I literally didn't even know what was happening to me, because she just made me comfortable, and I told her about FGM, that was my number one issues. And then she literally said, I understand what you went through. I know something about FGM. And I didn't have to say much more after that. At that stage, I was just like, oh my God, this is so good. Like, I want to see it every single time. So the support that I received that moment made me realize that it took me that long to see someone, but it's good that I did that, because I found someone who I can actually trust, and someone who let me share my story and, on top of my own story, give me a platform, and then be vulnerable without her judging me or asking me questions like type of what FGM, what have they used, have you seek other medical help before, all this stuff. So it made a lot of sense. And from there on, I'm working with her with coping skills, like how not to feel guilty and how to look at myself and tell myself I am beautiful and I'm not just a girl with no clitoris, I'm just a girl who's ready to move on from her past and then build a bigger picture and future, and then help other people that are going through this similar situation, And I have friends that have gone through FGM, but they're not ready to share their stories. And I understand that. They said to me, bravo for telling your story. I feel like I am sharing my story, but I'm also sharing the story. But using my perspective as a Fatu's story, but they're behind me, supporting me continuously. And that's what I always say to everyone who always want me to get my friends to say their story. I'm like, they're not ready. I can't force them to talk their story if they're not ready. And that's their platform. And we should give them chance and time for them to heal from that, And coming from an African background, family is a massive respect. Family will respect our culture. And I have no family. It could be maybe because I don't have family here. That's why I'm voicing up about FGM, because I haven't got anyone to tell me you can't talk about that. I learned to figure out what I want to do for myself. And some of my friends that have family here who strongly still believe in it, and they don't want to disobey their family. And that's why I always say to people, I'm like, I can't force someone. Like, you know, even I go to their house or I respect what they believe in, and I still respect that space, but they know what I do as well. They respect that as well, you know. So I'm not. So every story that I share is from myself, my perspective, my journey as a survivor, and what I have heard from other friends who have gone through FGM. Yeah.
Thank you, Fatu. Thank you for sharing that. And I really underpinning or underlying that is really that give everyone time. Everyone needs time. And I think when we build that sensitivity, the understanding, then we're better able to understand that, you know, and you know, to give our patients the time or the time to really understand those issues and allow them to open up with that trust, having built that trust and understanding and respect for other cultures, and then they're able to open up and get the help they need.
I never used to talk about FGM to anyone because I feel ashamed, especially to girls, you know, because I just feel like I was missing something that I can't contribute in a conversation regarding sexual, you know, or relationship, anything like that. So it took me a while, and that's massive as a female, you know. So
yeah. Fatu, the other thing I'm seeing that's coming up, which you spoke about, I mean, having undergone female genital mutilation, and you spoke about urinary tract infection initially. And my thinking then, yes, it's predominantly a physical thing. But I understand you're seeking care from and understanding your situation even better, that it's not the obvious physical. There's also almost a mental health issue to it, because it seems you're getting care from a psychologist and you talk about all these emotions. Yeah. Explain, so it's broader than just a physical issue.
Oh, definitely. Urinary tract infection, it's like when I was mutilated at the age of 6, I never used to go to the toilet because it used to be so painful. And growing up and as an adult now, like I can stay the whole day without going to the toilet. And then you don't know the effect of that. But I'm like, okay, this is why it's still there, because I'm thinking I am still mutilated. I'm still going through that pain. Then I will stop going to the toilet because I feel like it's painful. So working with psychologists to tell me that you do know that that's a past now. You're in present and you can use the toilet without feeling any pain. So it's a journey, and I'm not saying that I'm at the point where I can actually go to the toilet maybe 3 times a day. No, I'm not. I'm still working on that, and I'm still training my brain to say that you're no longer in pain. You should go to the toilet when you feel like you should go to the toilet. And that's what I'm trying to do every day. And seeing that psychologist, she helps me, like check up on me weekly, like, have you done this, have you done that? And that's helping me a lot. So it's not just the physical, and it's just the mental thing about it. Like I get hot feet at nighttime, and that's due to nerve damage as well. And sometimes when I go to bed, I have to wear a wet sock. It sounds so weird, but that's the only way I can sleep at night. Or even wintertime, I have to put the AC on just to cool my feet down a little bit so I can fall asleep. And those are part of FGM. And like I say, growing up, you figure out all this stuff. And I'm seeking help, but I'm doing it one step at a time. I'm doing it according to how I want to live my life and people that I trust most.
Thank you, Fatu. Thank you so much for sharing your personal story with us. And I think this is, you personify what it is we're talking about today, what we're advocating for when health systems or medical practitioners work together with the community and young women in addressing and dealing with issues of female genital mutilation. And there's that holistic care, the sensitivity. We really do reach optimum health outcomes. It's taken Fatu 28 years to get to this stage, but we're thankful that she is getting the healing and the care that she needs with her working with her doctors. Thank you, panelists, for sharing. We'll now open it up to the floor and take questions from our audience members who've been watching to ask questions specifically to the panelists around issues of FGMC. The first question is from Lisa. I'm wondering if I should say the name. Lisa would like to know if women with FGMC are being screened for cervical cancer and how this is performed. She says many thanks in advance.
So yes, they are being screened for cervical cancer, and that they're being screened in exactly the same way as all other Australian women. There is no additional requirements for women who have FGM.
And there's no need to consider that they might have an increased risk of FGM, of cervical cancer.
So HPV testing, yes, it's occurring.
That's the way to go.
And women need to have their regular tests. women with FGMC and women without FGMC.
Thank you. Thanks for that. Our next question is from Sonia. I'd be really interested to have a list of all countries that do this reference to female genital mutilation, that practice female genital mutilation. We tend to know the main ones, but are there ones we aren't aware of that we should be knowing?
I'm not sure which main ones that you know, but you would definitely get a full list from the World Health Organization website. You will also get it from UNFPA website, and you get it from the UNICEF website. But for this webinar, I'll just quickly go through a few countries for you. And I'm looking at countries that are also represented in our community in Australia, because that's what is relevant here. Ethiopia, Eritrea, Nigeria, Central African Republic, Somalia, Kenya, Tanzania, Uganda, Sierra Leone, Liberia, Guinea, Gambia, Ghana, Senegal, Burkina Faso. And these are mainly African countries. And then we know that there are other countries in the world, because this is not an African issue. So there are countries like the Yemen, Iran, Iraq, Indonesia, Malaysia, and parts of India. Now, when we say these countries, we're not saying these are population-wide practice. There are percentages, and there are different ethnic groups in each of these countries who practice.
And South
Also
Africa,
Egypt.
yeah, and
Egypt as
South
well.
America,
Yeah.
sorry, due to the migration of people. So South American just come out.
Okay, thank you. We also do have resources on our NETFA website for more information around the countries there.
Maybe if I could just add, Boy, that we do have some good prevalence data in some countries due to demographic health surveys. So we have some understanding of what the percentage of women that are cut, but in many countries we don't. So for example, Malaysia and Indonesia, we don't really understand how, what the levels of FGM are in various communities. So we don't have a lot of information in many countries.
Our next question is from Tilly. This was answered in part, but I'm going to pose it in full because of the sensitivity of it, and I think it's good to clarify and reiterate again. But Tilly asks, what is considered best practice if a health professional feels the need to respond to families where the risk of FGMC being performed on a child is identified? What is the duty of care of the health professional in mandatory reporting? Is reporting this risk insensitive to women and families?
Yep, that's a very good question, and certainly this is a question that's been played out a few times in the last few years. So I have knowledge of health professionals who've been asked about whether they could help them with the procedure. And I think the duty of care of all of us is to categorically say it is against the law in this country, but it is also against the law to aid and abet someone to take the child somewhere else to perform this procedure. So we don't need to talk about, what has happened with court cases and stuff. There's been very few, really, but we do need to acknowledge that our duty of care is categorically to say it is against the law, that it's a rights issue, and that we don't support this practice in this country, but we will absolutely meet you where you're coming from, understand where you're coming from, try and work out what it is that you want for your child, and try and, discuss how you might perform a ritual celebrating that girl in another way that's culturally appropriate. And there are so many wonderful rituals across the different parts of the world that are actually celebratory of children or rites of passage as well. So I think we need to be aware of that. We need to acknowledge that many communities do have that strong need to celebrate rites of passage, and we need to allow them to do it in a way that doesn't harm children.
And I think it's very important for us to also take into consideration the fact that a lot of our communities did not understand what female genital mutilation did to them. They were very focused on the celebrations, the rites of passage, and the value that female circumcision is to them in their cultures. On arrival in Australia, a lot of our communities then come into contact with our law, and then they come into contact with the programs that are used for awareness raising. It's when women receive the awareness raising, and the men as well, that they begin to question, why is this necessary in my culture at all? And once they understand the health effects especially, and mind you, the health effect is not only the short term or the effects around maternity or effects around, it's a whole lifelong effect. And I'm really wondering whether we've taken into care aged care. Because the women who've come and migrated to Australia are now beginning to go into the aged care cohort. And what is going to happen to them there, and how are aged care workers prepared to support women in those kind of situations. So imagine yourself in a village where everybody is circumcised. And then you're out of the village where many people are not circumcised. And how do you deal with that situation? These are the things that the community education programs are living with and supporting women through. So it's health, and then it's the community as well. And it's really important to understand that all that is happening. Campaigning is not the way we're going in Australia. We don't campaign against FGM. In Australia, we educate. Because we understand that people have brains that they think with, and when you educate a person, they will use that information to make effective decisions.
I think I agree with that. Like you said about the sense of belonging where people are mutilated and people that are not mutilated. I felt that pressure as a young teenager, 6-year-old, where there's a society where girls that are mutilated, they belong in that society, and you're considered as a boy. And that, even though at that age I knew that this procedure was painful, but I wanted to belong in that group because I wasn't educated, you know what I mean? But if there was education there and then someone taught me or my family what the consequences were, I wouldn't have gone through that FGM, but I wanted that party, I wanted that new outfit, I wanted to belong in that little group of society, but not knowing that that group of society goes through so much pain. And a lot of women are not even educated on the fact that like they don't even know if you're mutilated the first time or second time. I was almost mutilated the second time, but I had to run for my life. And this little mark on my shoulder here, that was because I was running so hard I scratched myself because they wanted to mutilate me a second time, and I will never forget that. So if there's education, I wouldn't have to go through the first one or the second one. I would have just say, no, thank you. I don't want to belong in that society. I want to belong in this where I know I am a woman and my clitoris belongs where it belongs. You know, you have no right to touch me. You know.
I think something else that we need to remember is change takes time.
Exactly.
And so having a zero tolerance approach might, globally be a good catch cry, but in reality, communities not only need education, but they need time to think and to change their behaviours. And alternative rites of passage, as have been trialled in Kenya and in Sri Lanka, for example, didn't happen overnight with a couple of education sessions. So we need to be patient, but also work within the law. So it's a balancing act that we all must do.
And we do know that change takes time, but change is happening.
Yes, it
We
is.
have good evidence from elsewhere in Europe and also the Australian evidence that suggests that communities have changed their practices, that there's a definite decrease in wanting this practice for their own daughters. So I think that's very worthwhile remembering. So we need to work on that basis.
No, and from a grassroots level, as others have shared, because of the bilingual community educators who are champions from their own community, who understand it and know the consequences, and they are like vanguards to bring about that change. And people respect them, and they have credibility to take the message back to homes in Australia.
So change champions.
Change champions, yes.
Really
Yes.
important. Yeah.
Yeah.
Thank you for that. We'll take our final question from Nicolina. Nicolina asks, and in brief, panelists, one or two of you to respond to this, but do we find parents living in Australia going back home to have FGMC performed to their daughters?
So yes, we do know there's a case before the courts in Queensland
now,
at the moment where a father took his daughter overseas to have her circumcised. So there is evidence that that's occurring.
Yeah. And again, there was another case where people had come in this state that come asking about wanting to do it, and I think there was a preemptive long arm of the law that went out. So these cases are very few and far between, but I'm sure the community would hear much more about those wanting to do it. And I know of cases in the UK where girls have been taken back to home countries or another country to get the procedure done.
I think a lot of the people who would be asking...
I'm counting down now. You can, in
who
short.
would be asking to take their children overseas would be people who have not participated in our community engagement education programs. Exactly. Because I know those who have participated have changed their minds very much so. Thank you.
Thank you. Thank you for that. Sincerely and dearly, thank you, panelists, for your contribution for today's webinar. It's been very informative, educational, and I think we're going to continue to work together even more. To our audience members who asked the questions, thank you so much. I do note that there are further questions that are asked around resources, accessing resources, and those will be made available. I've got all your contact details, and I will be in touch after this, and we can share further resources, because this is about building the knowledge, the education base, and support and awareness. One thing that was key and crucial that I've picked up is that this is really a multi-sectoral approach. We need all stakeholders to come on board if we really are going to end female genital mutilation and circumcision. It's your doctors, your community, the women, those in the policy setting, those working in women's health. We need to work together to bring about the solutions and change that we're talking about. So that is it from us today. NETFA's the NETFA project that has brought you this webinar, the key message is that all women and girls who've experienced or are at risk of experiencing female genital mutilation have the right to high quality, safe and person-centered care. And that's the core of what we've discussed here. That is the core of what we're advocating for. And having consulted widely with the community and with health professionals, this is the core of our work for the next year and a half. Beyond this webinar, we are inviting you to a conference that takes place next year in February 2020. We'll share more information around that, but it really is a platform to further open up this dialogue, bring out the evidence and how we advance practice here, best practice, and really have that all-round multi-stakeholder dialogue to bring about these solutions and better health outcomes for all women in Australia, as should be. So thank you so much for tuning in, logging in today and watching our webinar, being a part of our webinar and the interaction through your questions. That's it from us, and have a good afternoon.